everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. Welcome to our community. This is a topic that a lot of you send us questions about, and that is, what can we do to actually minimize the chance of getting dementia? Well, I'm happy to report that credible scientific research is now going into this. And joining us today is Dr. Eric Larson. He's a senior investigator at Kaiser Permanente, Washington Health Research Institute, joining us from Seattle. Welcome, Dr. Larson.
Nice to be with you. Thanks.
So let's talk a little bit about the study that you conducted and was published in Lancet about really proactive steps that we can take to minimize our dementia risk. So I want to start this conversation with overall, how much are we in control of in terms of preventing dementia?
Well, that's a $64,000, maybe $64 million question, and it's debated. But we concluded that it's plausible that perhaps up to 38 or 40% of the risk that a person has of getting dementia could be modifiable, and we came up with a life course diagram showing how everything from the kind of nutrition and education and early childhood development that you experienced all the way up to when you developed hearing loss and could correct it. A series of events, when added together, could reduce your risk of dementia or Alzheimer's disease.
Its potential, right? So now, I mean, I'm fascinated with the science behind lifestyle studies because, it's the one thing we kind of feel like we're in control of, from diet to exercise. But what is it? It's hard to talk about them all as a group because there's a lot of different things. So let's prioritize here. The study that you ran in the Lancet, was there one particular area that really surprised you the most?
I was not expecting to see that much of a change related to reversing hearing loss. That was a surprise. I didn't expect that going in. And the other surprise was how many of the things that we think are beneficial to reduce risk for Alzheimer's disease are beneficial to reduce risk of not being healthy. So they're basically general health kinds of things like habitual exercise and controlling blood pressure and not being too far out of line with your blood sugar and so forth.
So let's first unpack the hearing loss, because I'm actually interested in that as well. Hearing loss is often associated with cognition, right?
Right.
But why is it associated with dementia?
Well, there are at least two possibilities. One is that hearing loss isolates you, and social stimulation seems to be valuable to prevent cognitive decline. And also hearing loss can somehow not stimulate the part of the brain that would normally get that signal. The other potential is that hearing loss is caused by Alzheimer's disease. And we know that there's a type of hearing loss which is distinguishing sound from noise or important things that you want to hear from the noise around it. That's a complicated cognitive function. And that may be the most important marker, and it may well be that that's intrinsic to the disease itself. So there's a lot of open questions around hearing loss. And then it's really clear that if you have it, it's wise to try to correct it.
And then what you found surprising was that once you did correct it, cognition improved. Is that right?
Well, this study in the Lancet was really a compilation of research from around the world. And in general, there's some evidence that correcting hearing loss reduces the rate of cognitive decline, and it also clearly improves a sense of well-being and avoid depression.
Right. So I wanted to ask you a little bit about, I think what you were referring to are some of the comorbidities we could actually keep track of, right? So we know like what's good for the heart. We hear doctors say all the time is good for the brain, glucose levels. But to what extent, with technology now coming out with all of these monitors, I just tested a continuous glucose monitor just to see how I metabolize things. Do you think we're headed in that direction as possibly a gauge for our brains to really monitor these types of things, to understand really more what's going inside our bodies that could impact the brain?
Yes, I do. I think there's a movement called the measured self, which is what you were experiencing with a continuous glucose monitor. And there are stories, if you will, anecdotes of people who detect an uptick in their glucose level. They change their diet or exercise, and it goes back down. And if we know that the higher the glucose, the greater the risk of Alzheimer's, then you're probably doing something if you measure that and can act on it. And the key is to act on it. People that count their steps every day or whatever measure of physical activity, again, you can measure that and act on it. People that monitor their sleep, for example, if you find that you're not breathing well at night because of your sleep, or you're having disordered sleep because you drank too much after dinner some night, those are the kind of things that you can actually probably act on.
Yeah, it's really interesting now how we have much more control over what, before we used to go to the doctors and everything was in a manila folder. Now we actually can detect things. So let's unpack glucose a little bit, because I'm actually fascinated. Now, glucose, as I understand, is the natural source of energy, fuel for our brains. Right. But as we age, we decrease in glucose, like we don't process glucose as efficiently. Is that a fair statement to make?
With all these variables that happen with aging, there are like bell-shaped curves of some people are at one end, the other end, or in the middle. And say with glucose, for example, many people find that their insulin is not working as well as it could be. They may have a state of relative insulin resistance, or they may have severe insulin resistance, in which case they have a form of diabetes. So we showed in a paper by my colleague Paul Crane that was in the New England Journal now some years ago, that at any level of glucose in people without diabetes, their risk of Alzheimer's disease and dementia is higher. So if at a public health level or at an individual health level, if you find that your glucose level is coming up, or if a community like, remember New York City, when Bloomberg was the mayor, their blood sugar levels were going up. Bloomberg said, I'm going to do something about this. I'm going to outlaw these high glucose beverages in two quarter or whatever size bottles they were selling them. And the level went down. So right. In theory, anyway, that social policy might have affected the New Yorkers' risk of becoming demented. Just like if you start to see your glucose level, or I start to see mine going up, maybe I need to take in less simple sugars.
So is there a range that we should all aim for? This is what kind of puzzled me, because as I was monitoring my glucose, you have a range between maybe, 70 or 60 or 70 to 120, which appears in a green band as kind of the normal range. But is it different for everyone? Can we standardize glucose?
Probably not, but I think you could go by the general guideline that lower is better if you don't take drugs that make it lower by on purpose. But if you walk around with a glucose level that averages out in the sort of 85 to 100, you're better off than averaging between 105 and 120.
Right. So what is it that we can monitor to really, like, what are the, the kind of red mark? I mean, you can, measure your A1C levels, which is like to know if you're in a pre-diabetic range. Are there markers within that we should be checking on or asking for in our physicals when we go to the doctors each year? I mean, a lot of these tests aren't necessarily standardized. So what should we know, and what should we be asking to be monitoring brain health?
Yeah, it's a very, very good question, and it's hard to answer as precisely as I'd like to. For example, I don't think people are recommending screening for hemoglobin A1C unless there's a reason for it. But it's a reasonable thing to ask yourself if you think you're wanting to do everything to possibly check your A1C. It's a reasonable thing to check your hip waist circumference ratios and see if you have gone the wrong direction in terms of hip waist. That's another measure that correlates with insulin resistance and adverse events. So there are ways to get at, say, glucose and insulin resistance, but some other things are just simple physical activity and making sure that you're getting at least the minimum of level of physical activity that's recommended, which is, the recommendations vary, but something on the order of 150 to 210 minutes a week of moderate to less moderate activity. That for people who are completely inactive, that's the very worst you can be. But so if you're completely inactive, just getting up to 15 minutes a day, most days of the week will reduce your risk.
Well, it was really interesting to see when I was wearing the continuous glucose monitor that, like, one of the things, like, you realize what foods spike your glucose levels. And cherries for me is one where it sends it soaring. But then if I ate a bowl of cherries and then went for a walk, it would come down right away, right? And so it's really interesting to see how exercise interacts with, just our biological systems, and how you can kind of bring those levels down.
Right.
If I want to eat my cherries, I know I have to go for a walk after I eat them, or climb some stairs.
Yeah.
But one of the things that I think people are a bit confused about, that I'd love to give basic education, is, insulin resistance. What exactly does that mean, and why is that detrimental to our brain health?
Well, again, a lot of these mechanisms are not known precisely, but insulin resistant means it takes a larger amount of insulin from your pancreas to keep your blood sugar in the normal range. And when you produce more insulin, it's believed that has a direct toxic effect on the brain, or if it's not working well enough to keep the glucose or the blood sugar down, same thing. But it probably has to do with oxygenation, if you will, and damage due to oxidative events in the brain that are reduced in a state where you have less levels of insulin to control the blood sugar. So
the oxidative stress or something on.
Yeah. Mm-hmm.
Yeah. That makes sense. So we talked a little bit about exercise and diet but I want to know, is there enough? I mean, I was so glad to see that this study that you did was published in Lancet, and I feel like we're just at the beginning of people taking lifestyle research seriously. Is there enough of it going on today, or what areas do we need to explore more to really understand more about our brain health and preventing Alzheimer's?
Well, there's probably a spectrum of areas that you want to understand better. It ranges from knowledge about behavior change. What is it that motivates people to exercise more, or to control their blood sugar, or maybe not drink so much alcohol, or control their blood pressure. And that's one level of area of research, and we don't know a lot about that. And is it better to work one-on-one with a counselor, or better to work through social campaigns, media campaigns? So that's one level. And then on going way out on this, well, how do these risk factors work in the first place? You know, how is it that the hearing loss somehow is associated with the disease? Is it the disease itself that's causing the hearing loss, as I mentioned earlier, or is it just the lack of sensation to the brain and the isolation? And those are the kind of things that research can study. And same thing with the disease itself. It's very likely that there's not just one type of Alzheimer's disease. And if there are different types and we can understand them better, then again, either the lifestyle changes or the treatment that one could offer would be more informed. So there's huge opportunities for research in this field right now.
Is there a point where lifestyle, it's too late? You know, I mean, it's too late to go on that diet, or it's too late to start. Is there, I mean, presumably when you're on the path to Alzheimer's, when you already have been diagnosed and you're entering, you know, later stages, I'm assuming we know you can't really reverse that with lifestyle. Is that true?
No, I don't think so. I think you can change the trajectory. I don't know if you can change the molecular events in the brain that are behind a person's disability, but we did a study years ago where led by my colleague Linda Terry and published in Journal of the American Medical Association, JAMA. And we showed that for people, for pairs, dyads, caregiver victim, if you will, if you set up a program where they walk regularly, every week, several times, and also some behavior techniques, the people that got the treatment in a randomized trial experienced less physical decline and were less likely to need to go to a skilled nursing facility for behavior changes. So I think as long as you're able to do it safely, regular exercise probably affects the course of the disease.
Yeah, absolutely. It never hurts, does it? Unless you get injured, I guess. But, you know,
Yeah, exactly.
So what is it that, you know, when we talk about, you know, one of the things that you found was learning new things, right? Well, so I'm trying to cover the gamut. So we have education, diet, monitoring comorbidities, sleep. Did your study include sleep studies?
We did, and we believe that sleep is an area of importance. It's clear that people with disordered sleep or a lack of sleep are at higher risk. We don't know exactly how that works. There's a system called the glymphatic system, which seems to be important for draining toxins, and we'll learn more about that in a few years, I think. But common sense indicates that if you sleep much too little or a lot, way out on the spectrum of constant sleepiness, sleeping, you're at higher risk. The real thing about sleep that I'd like to emphasize, though, is that the over-the-counter medications that people take for sleep are actually very likely, if they're taken at too high a dose or too often, to pretty dramatically increase the risk of cognitive decline, and also run the risk of falling and other things that happen if you're having a soporific effect of a sleep medication.
And is that because like the sleep medications are kind of mimicking sleep and we're not actually going through the natural cycles of sleep?
There's something to that, but the thing that is most important in my mind anyway is that the sleep medications are mostly anticholinergic. And we know that acetylcholine is the neurotransmitter that is most involved. And we and others in France and elsewhere have shown that these anticholinergic medications, if you take too many of them, not just have a temporary effect, but actually increase your risk of dementia over time. So
Right.
it was a startling discovery when we first found it, because everybody thought these were short-acting effects and they'd go away when you stop them, but they apparently aren't.
Yeah, that's really interesting. When was that study published? I mean, was that a recent study, or is that
Well, we published our study in 2014, I believe, and the original study from France was published probably in maybe 2007 or 8 from a large data set. And since those two publications, it's been confirmed enough times to know that it's not a false lead.
What about, we're getting a question in right now from someone asking, what about the role of fungus in the body and its relation to Alzheimer's, as in the study done in England of Alzheimer's patients where 47% of those who were studied had a fungal problem? I don't know if you're aware of that one.
I might be aware of it, and if it's the one I'm thinking of, there was a study that seemed to find this fungus on laboratory slides, and my colleagues that are more expert than I in this are concerned that was probably a lab artifact. I don't think there's a strong relationship between the fungus, the fungi that I know, and Alzheimer's disease.
What about the role of ketones? We've talked to scientists before, and I guess there's not enough published research, but what do you make? I mean, we know ketones are an alternative source of fuel from our brain coming from fat, but they do cross the brain-blood barrier. So is there any research on maybe alternating from, a state of ketosis to a regular state? Is that good for our brains?
I'm not aware of anything that would meet everyday standards. We looked for that in a couple of procedures projects that I've been part of internationally and nationally. We didn't find any convincing research. I mean, it's a lot of these things. In theory, wouldn't it be interesting if that were the case? But we haven't been able to show it's the case.
But is it the case because there's just not enough research dollars going into these types of studies, I wonder?
Well, I mean, I'm a researcher. We like to have dollars going into research, and our country and some other countries, but especially our country, has been extremely generous. And I think if there's a plausible research project to test the ketosis hypothesis, it could be funded. And you have this short-term. The ketones are a challenge because you could do some short-term studies and measure cognitive function in various states of ketosis or not. But most of the things that we're interested in would be something that occurs over months, years,
right,
or more. So those are a little harder to study. And again, ketosis is mostly temporary. It's pretty hard to live off a ketogenic lifestyle, if you will, for your whole life.
So another question is about when we're talking about the sleep aids, is melatonin, over the counter, we can buy melatonin, but should that also be avoided, or is that different from the sleep aids you were talking about?
I don't believe that there's a danger in melatonin.
Right. And because we produce melatonin naturally, right?
Right.
Yeah.
I'm not aware of, I suppose there's some way you could overdose on it, but I've practiced medicine for many, many years, and I saw a lot of people use it, and it's probably safer than most things you'd use. Certainly better than, putting yourself to sleep with alcohol, or what's called a benzodiazepine sleeping pill. It doesn't cause you to lose your balance and fall, and all these other things that happen as we get older, and more likely to have things like falls if we wake up in a slightly drugged state.
Well, let's talk a little bit about alcohol, because it's a question we always get, right? 1 or 2 glasses of wine a night, like, is that okay or not? I mean, there's more research coming out that I think we just published a study on how it looks like it's not, right? I mean, what do you know about alcohol, and should we be dipping into our glass of wine every night?
Well, I think it's hard to make should statements about alcohol. I mean, if a person has a problem with alcohol, they have a problem with alcohol. And that's probably something that needs to be recognized and addressed. The conventional wisdom was that there was a so-called J-shaped relationship with alcohol level or alcohol intake and dementia risk and mortality and you name it. And that J-shaped is if you're at the absolute no alcohol level, you're at a slightly higher risk than if you're 1 to 2 drinks a day on average throughout the week. And that's the way that was measured initially. Now there's a study that just came out that you refer to. I think this was using, might have been one of the English studies, aging studies, and they concluded that any level of alcohol intake was more risky than no, or the next level higher. So it looked like a straight line. I'm skeptical that that's really the case, but we tried to have a clinical trial in the U.S. of randomizing people to get no versus some alcohol, and that study was scandalous because of the way there was some funding from groups that shouldn't have been funding the study because they had an interest in the outcome. So it's not. I personally don't tell people, don't drink to try to prevent dementia. I will tell people don't drink too much, and don't fall and hit your head because you drink, because a concussion isn't a good thing for reducing your risk of dementia. Some of this is common sense.
Yeah, but 40%, I mean, that's a big amount if we can really reduce our risk by that much. So you were saying a little bit earlier that, it's how did this study conclude the 40% risk reduction? How could you explain it to our audience?
So the study took what's called a life course approach and reviewed probably thousands of papers. A staff at the University College of London did all this research, and there were 20 or so of us international experts who were gathered to come up with a what's called a Lancet Commission report. And using that information, we looked at everything from genetics, the what you are endowed with when you're born, to throughout the life course. And there's in the paper, there's a really interesting kind of rainbow diagram of these little streams from pre-birth at conception to adolescence, early life, midlife, late life, and based on the evidence, we tried to assign the percent of risk that would be lowered if, in fact, these modifiable risk factors are modified, and each one of those, when you add them together, if they are truly arithmetically addable, ends up with a 38 to 40% potential reduction.
Wow.
It's very theoretical, but I think it's it's good enough information to act on as an individual and in terms of developing social policies.
And I mean, at the end of the day, if we're all healthier, our brains will be healthier too. The problem with the brain is you can't see it, right?
Oh, yeah.
We can see our muscles get bigger if we exercise, but we can't see our brain.
Right.
What about, final question, what about the APOE4 folks? How much risk mitigation can there be if you have a genetic, elevated genetic risk?
I don't think there's the evidence is hard to come by, but for many of the potentially actionable risk factors, that actionable nature doesn't change whether a person is ApoE4 positive or negative. If anything, there is what we call a genetic environment interaction, where if you have both E4 and the environmental exposure that's not good, you're in far worse trouble than if you had neither, or one or the other.
Right. So it's worth it. All right. Well, thank you so much, Dr. Larson, for joining us. And we love more studies like this. So we wish you all the best. Okay. And make sure you tell us when your next published study, because, all of these things are really useful for us, those who are either at an earlier stage of dementia, have dementia, or are worried about it. People like me who have a mom with dementia. So thank you so much.
Sure. Thank you for having me. And in regard to one of these questions about a list, if you want to refer people to anything, it would be that figure that I mentioned. And I know that's probably okay to send that around.
Yeah, I just posted in the chat the article that we did of the Lancet study that also links back to the study. So people should be able to get. Do you have a website too? We could let people know as well.
I do not. We're making one for our new study. The ACT study, which started over 25 years ago, just got refunded, and it's going to be 3 to 4 times larger than it's ever been. So we'll have a really whiz-bang website in a little while.
Wonderful. What does it cover, the ACT study?
The ACT study is looking at better understanding how we can reduce the risk and the mechanisms for reducing that risk across the life course. And it ranges from genetics to subtypes to 24-hour activity levels. So we know the role of disordered sleep and physical activity. We're going to be looking at drugs and glucose and their effect on cells in the brain at the receptor level to see if we can, with single cell cultures, find clues to the actual mechanisms where in the cell these changes are occurring. So it's a combination of classic epidemiology, which I've done for my career in health services, into the deepest and the best biology around. And we also have an affiliated study at the Allen Brain Institute, which is looking at proteomics and the detailed molecular changes that might help us decide why some people with lots of plaques and tangles in their brain die in their 90s and are not demented.
Right. Yeah.
That's been a puzzle for my whole career.
It's very,
we figured that out.
Yeah.
Lots of good stuff going on.
So we already have an audience member saying, do you need volunteers for this study?
Oh, thank you for asking that. We don't need volunteers. It's a random selection of the population that gets their care at Kaiser Permanente, Washington. So we call it an epidemiologically sound study. It's not a convenience sample when you use volunteers. Okay, well, make sure you come back and report on the findings. We'll be watching. I'll be glad to. I love talking. Okay. Yeah. Thank you so much, Dr. Eric Larson, for joining us. And bye. If you want more on this topic, don't forget to sign up for our newsletters, beingpatient.com. Write to us at info@beingpatient.com and let us know what you want to hear about. These talks are really for you to gain access to some of the world's leading experts. So thanks very much for joining us, and we will see you next time.